Good morning. My name is, if you guys don't know me, my name is Wesley. I'm one of the EMIM second years. Today I'm going to be talking about, I'm doing an EKG RADS pharmacology lecture. I'm talking about like pain control, options beyond opioids. Thank you so much for the EKG pharm and radiology team to give me feedback and suggestions. So my objectives today to discuss opioids, the overuse issues, as well as the opioid crisis, discuss the different pain modalities that we can use in the ED, and then encourage a multimodal approach to pain control. So the opioids are kind of derived from the opium, which is a narcotic drug, which is the main component of opioids, which is derived from the poppy seeds. I'm not going to pronounce the species because I'm going to butcher it. But the opium was first documented started to be introduced in the Western and Central Europe between like 16,000 and to 3,500 BCs. Initially, it was pretty labor intensive to extract this opium, of like drying this process and all this stuff to extract this stuff. But now we have pretty well things of how to create this into the opioids. If you want to hear more about the history of opioids, I will recommend Dr. Nguyen's talk in 2017 on our YouTube channel. So yeah, see, these are some of the most common opioids currently on the market, from the weakest to strongest going down. We have like codeine, tramadol, morphine, oxycodone. We have all the way up to fentanyl. One thing just to know that because of the illegal drug trade, like a lot with heroin, which is twice as potent for like morphine, but even with fentanyl is like now 100 times, and then carfentanil, which is like 100 times more than fentanyl. A lot of these illegal heroines on the market is now laced with fentanyl and carfentanil just because it's cheaper to kind of put it with other non-synthetic material. So just be aware. So this is some of the data from 2019 from the Health and Human Services Department about the opioid epidemic. As for the data, it's kind of showing the opioid epidemic is still alive and current, which is a lot of people. We do have a decent amount of patient population who is heroin and opioid users, not as much compared with some other parts of the country, but just to be aware that for our patient population. So yeah, the opioid has been around for a while, as I kind of mentioned, but the rise of the pharmaceutical role in the opioid epidemic began in the late 1990s to early 2000s, which kind of from the kind of concept of the pain as the fifth vital sign, which was introduced in 1996 into a great docu-series to kind of watch about kind of the opioid epidemic. I recommend it's The Pharmacist on Netflix, as well as The Crime of the Century on HBO. Not sponsored. But yeah. So like a lot of this current issues I mentioned is the rise of synthetic opioids such as fentanyl and carfentanil. Carfentanil, which is like a tranquilizing agent used for like elephants. It's like 10,000 more times more potent than morphine and 100 times more potent than fentanyl. So just be aware that that little amount of carfentanil, or as much as fentanyl, can cause an overdose for patients. A quick point about tramadol. Tramadol is often seen as a pain medication, often seen with our older patient population. It is an SNRI with an opioid metabolite. However, it's a weak opioid, similar strength to codeine. It's addictive, and it really doesn't really give great pain coverage. Like a recent study in 2019 published in JAMA showed a really overall mortality risk with tramadol use in patients with osteoarthritis. And it comes with a black box warning, including like lowering seizure threshold, causing serotonin syndrome, as is an SNRI, other drug interaction as is CTY40 chromosome interactions, as well as unsure why, but like hypoglycemia. And as I mentioned, it's a pretty addictive medicine overall. So one of the reasons that to kind of avoid using opiates for the long term is this concept of opioid-induced hyperalgesia. So this kind of concept is like the where patients who receive opiates for the treatment of pain can actually become more painful, sensitive to certain painful stimuli. The mechanism is not really fully understood yet. Kind of going between like neuroplastic changes, in this peripheral and central nervous system to kind of different sensitizations of the nervous pathways. Another kind of pathogenesis kind of mentioned in literature is kind of this NMDA receptor kind of activation, which is kind of why like ketamine is also used for some of these treatments for the opioid-induced hypoanagesia. But yeah, kind of from what this graph is showing for this like opioid-induced hyperanagesia, some of these people who are becoming like kind of desensitized to the opioid kind of pain concept is that as they kind of keep using opioids, the pain intensity is kind of increasing, but they're not really having that great kind of pain control. So just be aware of this kind of concept as you're prescribing opioids to your patient population. One of the treatments for opioids use disorder is buprenorphine, which is a partial agonist against the mu opioid receptors. It was approved in 2000 for the treatment of opioids use disorder. So yeah, just be aware. A lot of people prescribe naloxone, which is a combination of buprenorphine and Suboxone, which is buprenorphine and naloxone, which kind of help with that kind of treatment. We actually do have a pathway in county for the treatment of opioid use disorder. I haven't really asked anybody yet whether we actually been prescribing this yet, but I know with the X waiver kind of thing on in the law currently that we're still figuring out whether we can prescribe it without an X waiver. So yeah, so pain. A lot of our patient population comes in because of pain, whether it's headache pain, belly pain, back pain, neck pain, mouth pain for like dental pain, knee pain, all types of pain. And a lot of our treatments is to treat this pain. So pain is from this kind of spinal thalamic kind of tract, as we kind of learned in med school. It kind of goes from the peripheral receptors, goes all the way up to the brain, kind of where it registers as pain. But as we can kind of see from this graph, that we can target different locations in the pain pathway to kind of help treat our patient's pain. So one of the concepts I want to talk about is the idea of multi-modal analgesia. It's kind of this concept where we can kind of use multimodal approaches to kind of treat pain. The benefits is that we can use lower doses of our pain medications and increase the benefit and lower the risk of it. And then just a lot of these pain medications kind of act synergistically together to kind of work to have a greater effect on treating the pain. In some of the anesthesia literature, it's kind of using a lot of this concept of CERTA for treating pain, using different receptors in on the pain pathway to kind of treat them, and using different modalities and pain medications. As I can say, it goes from like COX inhibitors to dopamine receptors to calcium channel blockers to central alpha 2 receptors. So yeah, so my next part of my talk is going to be talking about the different modalities that we can use. The first modality I kind of want to mention is the non-pharmacological modalities, which is like the environmental, hot packs, cold packs, acupuncture, manipulations, physical therapy. One thing to remind yourself as you're treating pain is the environmental aspect of treating pain, making sure that you create kind of this like lower stress environment, even though it's a little bit hard in the ED, just to make sure that you can like kind of acknowledge their pain, make sure that you are giving them like kind of a lower stress level of around them, whether it's like dimming the lights and all this other things to kind of help with the environmental aspect of it. Other aspect of like with our colleagues in the DO pathway, they kind of understood a little bit more about the manipulation techniques with it. I don't know that much about it, but from kind of the readings I have, like there's been some good data between kind of just using these treatments to kind of treat acute pain for it. Acupuncture has also been kind of a little bit more being widely used in emergency medicine. A lot of studies kind of showing that, like, I think there was one study I read in Wisconsin, in the ED that was using offering acupuncture for kind of pretty severe pain, and it's kind of showing that even between acupuncture and morphine group, there was a kind of a reduction in time of kind of resolution of the pain from like 16 minutes to like 28 minutes compared to the acupuncture and the morphine group. Tylenol and acetaminophen is one that we often use in the emergency department. The mechanism of action is kind of unclear, actually. People kind of think it blocks the COX-3 receptor, kind of lowering the concentration of nitric oxide. Also has been shown to be a TRVP receptor agonist. Tylenol can be used both PO, rectally, and IV for pain. NSAIDs, we also use a lot, ibuprofen, indomethacin, Toradol. The mechanism of action is from the blocking of the COX-1 and COX-2 to prevent the synthesis of prostaglandins. Forms for that is both PO, rectal, IV, and Tylenol. Some of the adverse reaction that we should remember is, for NSAIDs is gastric ulcers, platelet function inhibitors like H. pylori infection, and nephrotoxicity. Topical NSAIDs I probably use more often in for like treatment of low back pain. Toradol also has been kind of shown in a couple of studies recently in 2017, 2018, that P4, like even using the lower dose of like 10 to 15 milligrams of IV can just be just as effective in treating pain comparatively to the 30 and 60 doses of Toradol that we've been giving. Gabapentinoids, which are our gabapentins and pregabalins, they are the ones that are calcium channel blockers. They come in both PO and IV form. Just to be aware, the majority of these medications for gabapentin takes about like 1 to 2 weeks to take full effect to kind of give great pain relief. A lot of it's for nerve pain and other kind of neuropathy kind of pain. Adverse effects of these kind of gabapentinoids are like dizziness, fatigue, ataxia, nystagmus, tremors, like angioedema. So just be aware, especially for elderly patients, to be prescribing them. I did a little bit of research on cannabinoids. Currently, there's not much literature about cannabinoids in using in acute pain. These are both for, they kind of act on the THC receptors, but we will see probably in the next couple of years about, especially as medical marijuana gets a little bit more studies about how to use this for both acute pain and chronic pain. Another topic to kind of think about is local anesthetics with our sodium channel blockers, with us like lidocaine, bupivacaine, like Nevi kind of talked about for dental blocks. They come in both IV, subcutaneous, topical, and intra-articular kind of ways. We use nerve blocks a lot in the ED, whether it's like femoral blocks for like a femoral fracture, for like a distal block to like repair hand lacerations. Just be aware of that. Another way we can do is IV lidocaine. There's case reports in 2012 that show that IV lidocaine with 1.5 milligrams per kg with like a max of 200 milligrams over like 10 minutes is just as effective as a IV morphine for the management of like renal colic pain, for example. These like blocks are pretty effective and have been shown to kind of decrease the amount of analgesia and like opioid use for that. So just be aware also as you're giving them just the renal, the systemic toxicity of these kind of medications that you're giving. Just be also like these come also in lidocaine patches in like topical form. I love them. I put them on basically all my patients with pain, just to, it's an easy way to just give them another pain modality to treat them. Another thing to mention is trigger point injections. This is like a easy way to kind of treat pain where you're basically taking like a 22, 25 gauge needle, putting at the site of maximal pain that the patient's talking about, using like a 1 to 2 cc's of like a local anesthetics and just kind of injecting it and do like a compass kind of mapping of like north, east, west, and south kind of thing to kind of help relieve the pain. It's been kind of pretty effective, especially for MSK pain. Another kind of solution is also for like intra-articular blocks, especially for like dislocations, for femoral, for knee pain. It's also a great way to kind of reduce the amount of opioids you're using for these patients. Precedex or Dexmedetomidine is a alpha-2 receptor antagonist. Some of the positives is that there's no respiratory distress, and actually maybe hemodynamically more stable in Propofol. Some of the downsides are bradycardia and hypotension. It's used a lot for our sedation kind of medicine, but it's been kind of shown to be also used for like a local anesthesia kind of for some of these kind of process. So it can be both administered IV, intramuscularly, orally, and intranasally. We use this a lot in our peds population. Just one study that I read was that intranasal, like 2 micrograms per kg of fentanyl was comparatively effective comparatively to the 2 micrograms a kg for Precedex for these kind of patients. So just be aware that you can use these kind of for these, especially in peds populations. Propofol is another way we can use. It's a GABA receptor agonist. Can use, we also think about as a sedation and like a RSI kind of medications, but it can be used to decrease pain perception and adjunct analgesia as well. And a lot of the literature only has been shown to be helpful in migraines and acute headaches as well, as I can show. So it's kind of just as effective in some of these trials, as I mentioned here, for acute migraines and headaches for these patients compared to like sumatriptan that we also often use. Magnesium is something that we often forget about as a pain modality. It's used as an adjunct anesthesia. It works in the MNDA receptor. A lot of the medications that we use is for like neuropathic pain as well as for like migraines and stuff like that. It's also been shown for some of the literature to treat like fibromyalgia, dysmenorrhea, and headaches as well. The literature doesn't really show, has been proven to show how much to give magnesium, but like magnesium toxicity is pretty high for like these 10 micro equivalents per liter. So I think giving like 2 micrograms for IV is pretty safe to give for a lot of these patients. Some of these studies that I kind of shown about fibromyalgia, for dysmenorrhea, and a lot of the literature is also for diabetes use as well, for hyperalgesia. A lot of the things are shown for migraines as well as tension headaches. Another thing I want to talk about is ketamine. We use ketamine. We like ketamine a lot, and there's a guy, Maimonides, who really advocates for ketamine for pain control. It works in the NMDA receptor. It's a quick onset, it's titratable. Some of the things to watch out for ketamine is for like laryngospasms, apnea, like emergent phenomenon. Some of the, we often think about it for RSSIs as well as like kind of constant sedation kind of medications. But for pain, we can use a sub-dissociative dose, which is like 0.1 to 0.4 milligrams per kg bolus over like a 10 to 15 minutes interval. And then you can actually give like a 0.1 to 0.15 milligrams per kg infusion for these kind of for these pains. There's also intranasal route, which is a good alternative for children. As I mentioned, it's a pretty quick onset for like 30 seconds to 1 minute for a lot of these patients. There was a study that showed there was actually no significant difference between low-dose ketamine and morphine within the first 60 minutes of analgesia, even though like in an hour to 2 hour kind of period, there was actually some favoring in the, of morphine, but for like acute kind of settings, giving like some low-dose ketamine can be really helpful to kind of reduce the amount of opioids you're using. Something to think about, we don't currently have this in America, but I think I saw some in Australia and in Canada that they're testing out ketamine sublingual doses for pain. So that's something to think about as we are looking forward to for different ways to kind of treat pain in our emergency room. So yeah. Some takeaway points from my lecture should be the emergency clinician should evaluate the patient's medical history and family history when opioids are being considered as a discharge prescription. I do like in HealthBridge that we have to fill out an opioid kind of surveillance kind of tool before we prescribe opioids. Pain management in the ED should be patient-specific and pain syndrome targeted. Should discuss both pharmacological and non-pharmacological options to treat the patient's pain. A multi-modal approach, I hopefully kind of stressed on, can be both synergistically improve pain with an less negative consequences. And both modal and modal approach should be included in discharge planning. Both short-term medication, when you get discharged them, remember to refer them to physical therapy as well as pain management consult as well. So yeah. These are my references. Do you guys have any questions?
So for osteopathic manipulation, if you want to know about that, there are two people in our department who are very, very good at that. One is Quinn, and the other one is Sinner. In addition, just as of interest, and this one interests Dr. Lucchesi, but the article that you showed, the second author there, who is the program director at Methodist, was our resident at Lincoln. Ted Gaeta. And he's very, very awesome with this. The other thing I just wanted to mention, I hadn't mentioned it before, is when you're using marking, be very careful. I would make sure I'm not in a vessel when I'm using marking, and I would not use marking IV like you, because I know of deaths from it when it can cause cardiac arrest and stuff, and that's why you have to use much lower doses. But I would always draw back and make sure I'm not in a vessel if you use marking. And one other thing, when you talked about trigger points, and they're good, especially if someone's having chronic pain, keeps coming back to the ER and they're not responding to NSAIDs or Tylenol, is not just using the lidocaine or the marking, but using steroids with it. So, and we have the triamcinolone suspension, and you can mix that with the lidocaine.
Yeah, Dr. Gershaman was just kind of saying that if you want to learn more about osteopathic manipulation, find Dr. Quinn as well as Dr. Sinnert. Just be aware when you're giving marcaine to not be in the vessel as well, and when you're getting trigger points to also give steroids as well with a lidocaine or buprenorphine.